So I think in the interest of time, we'll go ahead and get started here. My name is Sanjeev Agarwal. I'm the Chief Medical Officer for the surgical platform at J&J MedTech, and on behalf of J&J, I want to welcome all of you to today's symposium. I think this session is incredibly timely, just given the fact that this year alone, we've had several consensus statements and guideline documents published on the use of temporary MCS in surgery, starting with the AATS consensus document earlier this year around the surgical management of AMI and associated complications, the recent EACTS consensus document around protected surgery, and then finally the Tri-Society guideline statement on temporary MCS and adult cardiac surgery, which was a collaborative effort between both EACTS, STS, and then the AATS. I'm absolutely thrilled to present the faculty today to you, which is a group that collectively has a wealth of experience in this area. And I think you're going to find very intriguing their insights on how they've specifically used Impella 5.5 to evolve their surgical practices. And so with that, it's my pleasure to introduce Dr. Marissa Savasco from Penn Med, University of Pennsylvania, Dr. Kunal Kotkar from Wash U, and Dr. Sri Kumar Subramaniam from Centennial in Nashville. And so with that, I will hand it off to Dr. Savasco. Our format today is we'll have individual presentations, and then the second half we'll do is sort of a moderated panel discussion, and then we'll open it up to Q&A. So again, thank you all for being here today, and Dr. Savasco, I'll turn it over to you.
Hi, good afternoon. Thank you to the J&J Abiomed team for having me today. Great to be here. I was here 2 years ago too, and it's really a great turnout for the conference. It's great to see so many people. So you see my disclosures. So I'm just going to start off with, we all kind of know this. Anyone who takes care of patients, you do a tough case, you bring them up to the ICU, they look okay, but then you get a call, maybe their mixed venous is starting to drop, their urine output's declining, maybe they don't want to take the breathing tube out, so the pressors are going up. What do you do? So this is classic post-cardiotomy shock. You did a high-risk case on a patient with a low EF, and they're just not thriving post-op. And so we know that when we operate on these patients and they don't come out and just move forward in a typical standard way, you have a higher risk of length of stay, higher risk of morbidity, and a higher risk of mortality. So the vasoactive inotrope score, most of you have heard of, this is a way to quantify the doses of medications that these patients require. The higher the vasoactive inotrope score is, the higher the risk of poor outcome. So inotropes, they're important for low EF patients, but unfortunately they increase the work of the heart, they increase your myocardial oxygen demand, you end up with arrhythmias, they get VT, it can degenerate. High doses of inotropes and drugs, your ICU team doesn't want to take the breathing tube out, and then your patient's stuck. How else can we avoid this? Well, we used to use balloon pumps. I really don't use much of a balloon pump anymore. We've had problems with the balloon. They don't really do much. Do they really increase the cardiac output? Maybe in certain cases, high afterload patients. ECMO, we've never had a clinical trial. We use a lot of ECMO at Penn, but is there really a clinical trial that shows a benefit? Do you really want your CABG coming out and high-risk CABG coming out? They come out on ECMO. Tandem heart, I'm not sure anyone uses that anymore. Limited benefit. Is it even on the shelf in your hospital? So the Impella is what I'm here to talk about today, and this is relatively new, but becoming more and more commonplace paradigm for postoperative support for these patients. So who are the patients that are at risk for coming out on high-dose inotropes and needing support? So anyone with the low EF. So we're all asked to do cases on patients with low EF, CABG, valve, and these patients, you can have pump failure post-op. So EF 25, even under 35, depending on how you protect the heart, the duration of the case, there's a risk that they could benefit or come out on high-dose inotropes, go into post-cardiotomy shock if they're not managed well. And so they would be potentially benefit from the use of the 5.5. We know that anyone coming in urgently or emergently, we try not to do emergent CABG anymore, right? But if you have urgent inpatient CABGs, they come in with NSTEMI, they're at a higher risk for post-op complications. If their index is low pre-op, they have a low index going into the OR, they're at a high risk. And if they have end organ dysfunction, their creatinine's up, their bilirubin's up, they're congested, they're also at risk for needing a high-dose inotrope and prolonged ICU stay. So I'm just going to give a case I think is illustrative of a good use of a 5.5, and there's a different way to, you could make an argument to put this in preemptively, or you could do it postoperatively, and we can talk about that. But this was a patient I took care of, 72-year-old man. He came into the ER. He had a 1-month history of shortness of breath, chest pain, or chest tightness, cough, and palpitations. He was tachycardic. He had decreased breath sounds. He was edematous. You could see his labs. He had a positive troponin. In the ER, he had some VT. His X-ray looked very wet, and his EF was low. You could see his past medical history there. He had a stent back like 20-something years ago. His last known EF was normal, however, and he had your typical comorbidities. So this is what his X-ray looks like. Cephalization of his pulmonary vessels. His EKG is kind of ugly. His BNP and troponin are elevated, and his creatinine and his transaminases are also elevated. And so here's his echo. You could see really biventricularly not doing much. Not dilated, though, but pump not working very well. And there's a contrast image. He went right to the lab. So they did a right heart cath first, and you can see he's wet. RA is 15, his wedge is 25, he's not ejecting much, his index is 1.6. But there's room to optimize him, right? You have an SVR of over 2,500, his PVR is elevated too. So there might be room for medical optimization. But if you look at his STS score, you could see his risk of mortality is around 10% here, 9%. So high risk. The pictures from the cabbage, or excuse me, the cath didn't get put into the presentation, unfortunately, but it was a pretty straightforward. He had beautiful targets. Everyone who does cabbages knows what a beautiful target looks like. This wasn't small diabetic vessels. These were really nice targets. He had a CAB 4. Initially, the EF in the OR also looked. It always looks worse under general anesthesia. They vasodilate out a little bit. So his EF in the OR was around 10 to 15%. We did a CAB 4 and put an Impella in coming off pump. I weaned from the bypass with the device in. He did very well. And we brought him to the ICU. Extubated him post-op day 0, got him out of bed, got him walking around, tuned him up. Post-op day 5, went back to the OR, took out. I like to take my device out back in the OR under local anesthesia. You don't have to go back to sleep. And eventually he progressed and he did very well. He left the hospital after about 2.5 weeks after we got him on some GDMT. And you can see his echo. This was a recent echo. His EF improved for up to 40%. He had pretty significant MR in the operating room, but it totally resolved. So what we took a fairly high-risk cabbage. You could see with these kind of numbers, with this STS score, we all get asked to take care of these patients. It's not great when you see your echo looking like this, but he would need too many stents. Stenting wouldn't have given him a good outcome. And again, cabbage was technically feasible, straightforward to do. And the way to avoid having a problem would be to use the device, the Impella, and he was a perfect candidate for it. His EF was under 20. This was an urgent operation. He was older than 70. He had left main disease and triple vessel disease. I already showed you how nice his post-op echo was. And so this is a paradigm shift. Instead of just simply taking the patient to the OR after a couple days, tuning him up and doing the cabbage and hoping everything comes out okay, just come out, put the device in before you leave the OR. You don't have to, you're ICU proofing the patient. You don't have to worry about getting a call 3-4 hours later. Well, the pressors are up, his urine output's down. We send a repeat set of labs, his creatinine's up. So it's a preemptive device. It's a safe support device. You can avoid post-cardiotomy shock. I'm a VAD and transplant surgeon, but I do a lot of cabbages. But this way I can get the patients to keep their own heart. I don't want to do heart replacement therapy. If they can recover their function with revascularization, that's the best option for many patients. We avoid the high mortality. We avoid the long ICU stay. We unload the LV. We're always thinking from a heart failure surgery perspective to keep the LV unloaded and then get the patient extubated. It's much easier for the nursing teams and the ICU teams to take care of a patient with an Impella than someone with ECMO, even versus a balloon, a femoral balloon. You can get the patient with the Impella up and out of bed. You don't have groin complications. You avoid the rocket fuel, you avoid the renal failure and the CVVH. And really, there's very minimal hemocompatibility issues. And if you manage your anticoagulation well, I found that I switched to bivalirudin. I really don't use heparin much anymore, both pre or post-op. We have a lot less bleeding, a lot less, really never clotting. And again, I mentioned many of these already. Physical therapy can get these patients out of bed. We now have our patients on the step-down unit, not necessarily the post-cardiotomy patients, but patients who are being bridged to transplant. We have them not necessarily in the ICU anymore. We're an East Coast program, so we have a long wait, but they're bridged and they walk around our step-down unit with the device. You can get them, people are sitting upright to decrease the risk of pneumonia. Especially when we're being asked to take care of these patients in a public reporting environment, this helps us do the right thing for the patient and get them back home. So it's an out with the old and in with the new way of thinking. So now that I know that my senior partners are asking me to help them get the device in, I feel like there's been a paradigm shift at HUP. So it used to be people would think of MCS as being associated with a high rate of mortality. It was futile. It had complications. It was too complicated. No one knew how to manage it. Even the ICU team, everybody wanted to touch the buttons. Oh, there's no pulsatility. Is that a problem? Eventually, people get on board, and they totally understand that now this is an unloading device. You can do it safely. It's very easy to manage these patients. There's very minimal complications. It's kind of set it and forget it. In terms of placement, I think it's also straightforward. We can talk a little bit about that if the panel allows. And overall, I've seen the paradigm shift even within my group of other surgeons. And so instead of coming out and with the balloon pump and crossing their fingers, they're transitioning to use of Impella device, and it weans off within 3 to 5 days, and the patients progress much more quickly. Thank you very much.
Okay, thank you all. So I'll be carrying on with what Dr. Savasco just started with, and we'll be talking about escalating support and surgical decision-making and timely Impella deployment. By way of disclosures, not only am I speaker for Abiomed, but it's important to note that I'm not a VAD and transplant-trained surgeon. I trained at Cleveland Clinic, spent a few years in Leipzig, and I've been a cardiac surgeon for 16 years. So I have a high-volume, both mitral and coronary bypass practice. And I would also add my origin story to getting involved with Abiomed came when I heard a talk given by our competing group across town, and they presented a series of about 20 patients, very, very high risk, and none of them ended up on ECMO. And I was very surprised at this, and I went back and told our hospital administration that we're riding horses and buggies over here, and the competing group is driving Lamborghinis. And so that's what really got me interested, is seeing the outcomes that could be achieved in complex patients. So I'd like to start with this quote by Professor Bohr, who said that an expert is a man who's made all the mistakes that can be made in a very narrow field. And I will say I'm an expert in Impella. But with due respect to Professor Bohr, I've modified his statement in 2 ways. One, I've changed it to say, open parentheses, WO, because men are not the only people that make mistakes. And number 2, I would expand upon made all the mistakes by saying read and learned about, contemplated, discussed with peers and mentors like these meetings, analyzed, anticipated, and simulated and prepared for all the mistakes that can be made in a very narrow field. So one of the cases I'd like to present is a 50-year-old man who was admitted to our hospital, and I tried absolutely not to operate on this man. He came from a rural hospital in Virginia and was sent to our hospital in Nashville when I was on call for CABG with ECMO backup. And obviously very, very terrible coronary disease. And I told him it may be better to get operated near where you live, like perhaps the University of Virginia, West Virginia University, thinking that it's going to be a longer hospital stay. It would be better to get operated closer to home. And he said no, he would want to get operated in Nashville because it's closest to where he lives. So we sent him for an advanced therapies evaluation. We found he had a 2-centimeter renal mass. So now we have this with somebody that cannot get a cardiac transplant, and I'm not a VAD and transplant surgeon. So I asked my partner, why don't you do this, who's a VAD and transplant surgeon? He said, no, you do it because you're going to do the same thing I'm going to do. And if it doesn't work out, meaning CABG and Impella 5.5, then I will go ahead and do a VAD. And after we found the renal mass, I called him again and I said, are you sure you want me to do this operation? And he said, yes, you do it. So the other imaging on this guy was we did a cardiac MRI and he had a EF of 15 to 20, normal RV function. Only the apex and basal infralateral regions were not viable. And by the way, there was severe secondary MR with a regurgitant fraction of 50%. So 10 years ago, I would have looked at a case like this and said, this is definitely a primary VAD or transplant case, but now I view things totally differently. So I did the operation on this guy, a CABG mitral valve replacement. I did not take this video, but it was sent to me by one of our intensive care docs 10 days after surgery. This is with the direct aortic impella still in. He is putting in our ICU, golf putting, while his heart is recovering. And fortunately, he did well and got discharged about 3 weeks after surgery. And importantly, he got discharged home. It's an enduring benefit that I've seen with Impella is you take high-risk patients, not only do you get them through these things, but you discharge them home. They don't go to rehab. They're more likely to get discharged home. And obviously, being from a very rural community, being able to avoid a permanent VAD was a very, very big deal for this man. So one of the reasons I present this case is in 30 years as a surgeon, it's the case where I most felt that God was in the room. I actually felt the weight on my shoulder watching every single stitch. So that's kind of why I start with this case is not for ego, but just to emphasize that I think God's in charge. But it was just interesting how this all evolved to me operating on this guy. So I'll present two other cases about escalation. The first is a 40-year-old robust mechanic presented with a 3-hour history of chest pain and went into VT in the ER. He got multiple medications at this other hospital, so he had a rotating array of arrhythms, I could say, SVT, AFib, VT, got all these, got some shocks, intubated, got emergent cardiac catheterization. They placed a balloon and transferred him to our center. And I was on call, and this is his medical history: hypertension, hyperlipidemia, 2-pack-a-day active smoker. And the kicker is he's had a brain tumor resection, a right nephrectomy for renal cell cancer, left ureteral stents for kidney stones, and his EF is 10 to 15, moderate to severe secondary MR, and normal RV function. So when I heard about this guy and I looked at the images, I said to our ICU doc, I think we should immediately put an Impella in. And our ICU team felt they would try to get him tuned up and see because he was hemodynamically stable and not having further VT. Within 12 hours of coming to our center, he had escalating VT. So they called me and they said, you know, we agree now he needs a 5.5. So we went ahead and did a right axillary 5.5 on this guy. And you could say at the time we did it, it wasn't totally clear what are we ultimately going to do for this human and what is going to happen. But as I said, he's a very robust mechanic and working, and so he's a very active, fit man. But obviously he looked terrible at that time. So he's intubated now and he gets the 5.5 in. And within a couple of days after getting the 5.5, he's extubated, walking laps around the CICU, and we get a urology consult because he's got one kidney, he's got hematuria. And so it's not somebody that we rush right off to surgery, but we've escalated his support to getting Impella, and electrically he's stable after the Impella. So obviously, given the complexity of the coronary disease, we ended up operating on the guy. So this is his timeline. Day 0, the chest pain, VT, intubated balloon pump. Day 1, we took him in the hospital for the right axillary 5.5 and did a repeat cath because he was having more VT, and his MR was at least moderate. By day 4, with the Impella support, his EF had improved and his MR was reduced. And I ended up operating on day 9 because it took us a number of days to get all these things sorted out. And then I did an isolated CABG with a BEMA. I definitely favor arterial grafting, but I would say, given that history that I presented, I would not have been likely to do a BEMA on a guy like that. But having the Impella and getting him tuned up, I felt more comfortable doing a BEMA. Day 5, I decannulated the Impella bedside because that's my general preference, not to take them to the operating room. So I decannulated the direct aortic Impella. And then day 15, gets an ICD placed and discharged home again on day 17. So if you look at the day of operation to the day of discharge, he got discharged on postoperative day 8. So the intentional delay, optimization, electrical stabilization, all of that helped. And the MR grade was significantly reduced, so he was an isolated CABG, not a CABG mitral. Unlike the first patient with a 51% regurgitant fraction and severe MR, it was a totally different situation. The next case I'll present is one of postoperative escalation. So I had a 39-year-old man with a 2-day history of worsening chest pain, but actually exertional chest pain over the last month. And, ironically, also the same thing, hyperlipidemia, but congenital solitary kidney. I don't know if I'm a magnet for these single kidney patients or something, but active tobacco abuse. We see a lot of smoking in the community where I live. And his EKG with some ST depression, borderline ST elevation in the inferior leads. And during his cath, he went into VT, got shocked, heparin, balloon pump, and I don't know why they put him on also low-dose dobutamine at the time, just after the VT. But he arrives at our hospital at about 2 in the morning, and these are the images coming from the outside cath. So, extremely tight coronary lesions here, and the guy shows up at our hospital about 2 in the morning. And then, let me see here. This, unfortunately, was his chest CT. So probably a mixture of pulmonary edema and pneumonia. He's an active smoker. It looks like a mess. And in this case, the intensive care team is asking me, we think he's having ongoing ischemia. Will you operate emergently? He's on Vapotherm, 30 liters, 80%, and his EF is 35 to 40. That's with turning off the dobutamine and just leaving the balloon pump. So we had a discussion at that time about the options. Emergent Impella and doing a strategy like on the last case of escalating support, preoperative escalation, taking him to the operating room and doing an Impella CABG, doing an emergent CABG and possible Impella, doing an emergent CABG alone and see what happens, possible VV or VA ECMO, looking at this moment in time and not knowing what's going to happen to his pulmonary status, even if his cardiac status is stable to improved. And because of the concern over ongoing ischemia, I elected at that time to take him to the operating room, and I did an emergent CABG times 5. And these are the graphs shown. And he had actually pretty significant vasoplegia, so we had to use methylene blue in the operating room. And interestingly, I finished the operation about maybe 6 or 7, and my pre-operative sense was I should definitely do an Impella. I do this case, and he comes out and he's only on 0.02 of epi, and the EF with 0.02 of epi is not looking that bad. It's in the 30s. So at that point, I thought, well, we could either escalate now or observe and see what happens, and I elected to observe because after the methylene blue, when the vasoplegia improved, we had better coronary perfusion and better function. So I felt this is probably mixed cardiogenic septic, and or the mixed SIRS, and I've taken care of the cardiogenic, so perhaps this will get better. And later that day, his index started to drop, so his index was down to 1.7, and we were escalating doses of inotropes and pressors. So now we went from epi 0.02 to now 4 drips on a balloon 1-to-1 with a PAPI decrease during the day. So I asked the heart failure and heart shock teams to get involved because I really felt the best thing would be to take the guy back and put a 5.5. So that's what we did. We took him back to the lab and put a 5.5 in. So day 0 was that same day that we took him back to the took him to the operating room, did the operation, and then took him back later that day for the right axillary 5.5 and removed the balloon pump. And by the next day, he was extubated. Day 4, echo showed the EF was up to 40 to 45. And day 5, I decannulated the Impella at the bedside. And on day 8, he was actually discharged home. So it really emphasizes the value of looking at people in a longitudinal fashion. There are cases that you will benefit from preoperative escalation. There are cases that you'll definitely benefit from intraoperative escalation. And looking at this case in retrospect, I may have pushed more to intraoperative escalation, but like I said, we were on very low dose drips. So I think there's not a downside to waiting as long as you don't fall off the cliff. And so this is really, as Dr. Savasco said, a paradigm shift, because recognizing early and escalating postoperatively did not do this patient any harm. I was still able to get him discharged then home 8 days later. So thank you very much for your attention.
All right, good afternoon, everyone. My name is Kunal Khatkar. I'm one of the heart failure surgeons at WashU at Barnes-Jewish Hospital in St. Louis, Missouri. And as the last speaker, I have the honor of presenting a lot of repeat slides and repeat information, so I apologize up front. It's my disclosure. So as a heart failure surgeon, I think we also get super selected for patients who are high risk. And so as a heart failure surgeon who does LVADs and transplants, you also get cabbage and valve consults who have low EFs or who are otherwise high risk patients, just like Dr. Savasco said. And so we know with all our data right now that the patients who have the most benefit from cardiac surgery are the ones who are the most severe LV dysfunction. Unfortunately, patients with complex comorbidities are denied this kind of procedure because of the perceived risk of high postoperative mortality. There is definitely some lack of understanding of the prophylaxis for the treatment or the treatment of post-cardiac cardiogenic shock. And with healthcare public reporting on individual surgeons and their outcomes, there is definitely a sense of risk aversion. I think most of us are very careful about our star ratings, about our institutional star ratings, and hence we tend to refer these patients very often for what is essentially incomplete percutaneous PCI, or even incomplete inappropriate tears, sometimes inappropriate LV replacements, for example, LVADs or transplants. And I'm an LVAD transplant surgeon myself, but I know that the moment I do an LVAD or a transplant, the clock starts. It's not something which is going to last a patient for the rest of the life. The patient does much better and definitely has a longitudinal, have a longer length of life when the patient retains his own heart. And unfortunately, if we say no to these high-risk patients, the next discussion is palliative care or hospice. So I think as surgeons, as physicians who offer these procedures, it's also our responsibility to make sure that we are able to offer these to the right kind of patients. So the patients who have a high risk of post-cardiac shock, as we notice, is complex cabbage patients with low EF and poor targets. We also have patients who need an aortic valve replacement with low EF and who have severe aortic incompetence or low flow, low gradient aortic stenosis with very low contractile reserve, and patients who have severe functional mitral regurgitation with coronary disease with low ejection fraction. We talked briefly about what post-cardiac cardiogenic shock is. It varies significantly in various different series. Some series say that it's about 0.2% of patients, some say as much as 10%. And the mortality once the patient is in post-cardiac cardiogenic shock can range from 10% to almost 75%. As surgeons, we don't like to air our dirty laundry, so there's very little literature about what the outcomes of post-cardiac cardiogenic shock are. And it's most difficult to predict. But we all know it's also with low ejection fraction. And we also know that there's a deleterious effect of high-dose inotropes in these patients. Some surgeons in the past have tried to rest patients on long cardiopulmonary bypass runs, and that also does not help with this. And patients who have what we call the high vasoactive inotropic scores, we know that these patients who come out, just like Dr. Savasco said, on rocket fuel, patients who come out on high epinephrine, dopamine, dobutamine, vasopressin, epinephrine, now angiotensin, they are the patients who have the worst outcomes as far as stroke, mid-stenitis, postoperative renal failure, AKI, and mortality. So the higher the VIS score, the higher the mortality. So how do we estimate which are the patients who are going to have high risk of PCCS? So we all know the low ejection fraction. There's a study which suggests that every 10% drop in ejection fraction increases your CABG mortality by as much as 20% and your valve mortality by as much as 10%. But it's not the only thing we have to look out for. We have to also look out for other hemodynamics. Patients who have low cardiac outputs at baseline, patients who have low PAPI at baseline. These are high risk for patients developing PCCS in the postoperative settings. What about viability? We talked about patients who have good targets, who have bad targets, but what about patients who have poor viability? These patients who have poor viability, although they are good candidates for CABG, they have a high risk of PCCS. Patients with poor contractile reserve with aortic stenosis, aortic incompetence. Patients who are in compensated versus decompensated heart failure. Here I'm going to talk about it briefly because understand, a patient with an ejection fraction of 20% who's in compensated heart failure is at much lesser risk of developing postcardiac cardiogenic shock as compared to somebody who's in decompensated heart failure who's coming with a BNP of 10,000. So patients who are in decompensated heart failure definitely have a higher risk of PCCS. Let's talk about frailty. We talked about, I think we briefly saw a video of patients who are 75, 80-year-old patients with COPD who have other comorbidities. Frailty increases the risk of getting PCCS. And then end organ function, patients who have a creatinine of 2.5, patients who have an FEV1 of 30%, patients who have other end organ dysfunction. All these patients have a higher risk of PCCS. So it's important to adopt a risk-stratified PCCS recovery pathway with clear escalation triggers in all of these patients. And what we've done is we've adopted this strategy. This is the strategy which typically it actually came from the Cleveland Clinic. And once we have a patient who has a high risk of CABG or valve, based on their targets, their EF, their viability, and their STS score, we do a full workup on these patients. So these patients are worked up like a heart failure patient. They get echo, they get a right heart cath. We get viability studies in all our low EF CABG patients. And I personally like to use the MRI, but a bunch of my partners like to use the PET or dobutamine stress. We most definitely involve our heart failure team in the discussion. It's very, very important. For multiple reasons, I think it's very important for our heart failure cardiologists to be involved. To start GDMT. Let's not forget that four-drug GDMT, if possible in the preoperative setting, can improve their postoperative outcomes. And then even after you revascularize these patients are going to be heart failure patients for some time, and they are going to need GDMT and postoperative cardiology management. So involving them very early on in the discussion, introducing these patients to these cardiologists early on in the discussion is of paramount importance. We also do a small social work evaluation, and that's because we are a tertiary care institution. We can offer LVAD, we can offer transplant. So say I'm offering a patient a high-risk CABG with Impella assistance. I also want to know, does this patient have an exit strategy? If this does not work and the patient cannot come off the Impella, does this patient have an option of getting an LVAD or a transplant? If the answer is yes, then it's good to plug in this patient into the system very early on. If the answer is no, the patient deserves to know this, which goes into our shared decision making. The patient needs to know what the patient's options are and only then make a choice to go ahead with these high-risk procedures. So once we have this evaluation done in our group, we decide whether this patient has a high risk of requiring postoperative MCS or a low risk of requiring postoperative MCS. The patient then goes to the operating room where we, again, under anesthesia, evaluate the patient under TEE, put a swan in, look at all the numbers, and that is the time that we decide whether this patient is going to require postoperative MCS or not. And once they decide that the patient is going to require postoperative MCS, we will always come off on postoperative MCS. What about the various options? We know about the intra-aortic balloon pump. It's been used probably for the longest time, and even now it's the commonest device used for postoperative cardiogenic shock, but we know it has very, very little benefit and almost no survival benefit in postoperative cardiogenic shock. What about VA ECMO? No studies done in this particular group of cardiogenic shock patients, but we know in failing hearts it increases the afterload, and there is no LV unloading potential, which means this patient who has a poor LV function has a higher risk of pulmonary edema and hence delayed recovery because their LVEDP is high. Then what about 5.5? We've heard two other speakers talk about it. It does active LV unloading. It facilitates end organ perfusion and mobility because it's either an axillary insertion or direct insertion, so you can extubate the patient early on, you can mobilize this patient as much as possible, and especially in combination with VA ECMO, it has been extensively studied and shown to have good outcomes in postoperative patients. Why do we think it's a good option? Well, if you look at AMI cardiogenic shock, definitely a different type of shock. But if you look at AMI cardiogenic shock and all the studies, look at the STEMI door to unload pilot trial, look at danger shock, the only trial till date which has shown any survival benefit in AMI cardiogenic shock. These studies tell us that unloading the ventricle has a mortality benefit. And if you were to extrapolate this information to our postoperative CABG patients, we know that unloading the ventricle in the postoperative period reduces or spares toxic pressure effects. It maintains end organ perfusion. So if you have a patient whose creatinine is 2.5, 2.6, and you're worried that this patient is going to require dialysis in the postoperative patient, especially in high pressures, you want to reduce that. It also allows time for the body to metabolize the inflammatory cytokines and to recover from the cardiopulmonary bypass-induced myocardial dysfunction. So as we always tell our patients, you're going in with a sick heart, you're going to come out a little sicker. We want that sicker heart some time to recover. And it gives us some time, right? We also need time to see, to look at LV recovery. This device would give us time to assess LV recovery. At this point, however, we don't have data, but we need more prospective data on timing on unloading of PCCS, and maybe that's something which the IMPACT trial is going to show us, is what is the timing going to be like, what's the impact of Impella usage in our postoperative patients. The first study on the left, it was done in a patient where they did a PCI of the LAD and the circ, and they put an Impella in the patient, and this was an Impella CP. And with the Impella on, and they did a gallium scan with the Impella on and the Impella off, and what it shows is when the LV is unloaded, the perfusion is definitely better. The second study, which is on the right, that is a study which was done in sheep. And what they did was they did percutaneous LAD occlusion. And they put an Impella in some of them, and they did not do an Impella in some of them. And what they realize is that even when you have a complete occlusion of the LAD, if the patient was just unloaded and then revascularized further, the overall MVO2, the microbial oxygen requirement, and the ejection fraction is better in patients, or at least in sheep in the study, where the unloading was better. This is a study which shows that this was a study done in swine where they found the same thing, that when you unload these ventricles and you have myocardial ischemia, and if you unload them, then the signaling is not only at a myocardial level, but at a cellular level. There's even less mitochondrial damage, less cell death, less cell apoptosis signaling. So in essence, what we know is what Impella will do in our postoperative patient is reduce the risk of myocardial damage and improve cardiac improvement. We saw multiple cases today about patients where Impella was used in a post-cardiectomy setting for CABGs. This is my patient, which was not a CABG patient, but something similar. This was an 81-year-old patient with severe aortic stenosis. He was interestingly evaluated for a TAVR 2 years ago, and at that point of time, his ejection fraction was fine. But unfortunately, his annulus was very large, and they, at that point of time, did not have a device to fit that annulus. And he just got lost to follow-up. It is unfortunate that this patient never got referred for surgical AVR at that point of time. And he presented at an outside hospital with shortness of breath and fatigue. The patient also had COPD and obstructive sleep apnea, chronic kidney disease stage 3, iron deficiency anemia. And this patient lived remotely in rural Missouri. This is the ejection fraction. And so at this point of time, the EF is about 15 to 20%. The RV function was moderately down. Patient has severe MR at this point, and obviously severe aortic stenosis even now. Echo showed an ejection fraction of 15%, and it was diagnosed as low flow, low gradient aortic stenosis. The CAT showed, thankfully, no coronary disease, but a right heart CAT showed an index of 1.2. Now, of course, this is on the background of aortic stenosis, where you're going to have low index, which is a fixed index, but this was really, really low. In this patient, I tried to see if there's contractile reserve. So I convinced my cardiologist to actually do a stress echocardiography. It took a lot to convince them. But what it showed was that the gradient improved with dobutamine, which tells me that this ejection, this left ventricle, even though it looks bad, still has some contractile reserve. So in essence, this is a patient with low ejection fraction with severe RV dysfunction, severe aortic stenosis, severe mitral regurgitation, age of 81, COPD, and reversibility, right? So this is a high-risk patient for this valve intervention. I took this patient for an aortic valve replacement with mitral valve repair, and based on our risk stratification and our discussion about postoperative PCCS, we put an Impella 5.5 at that point of time. We did a 27 millimeter Magna Ease aortic valve and a mitral valve repair using a 30 physio ring. The patient came off cardiopulmonary bypass on 5 of dobutamine, no pressors, no other inotropes. Index was greater than 3. Postoperatively, the patient was extubated as usual 1 hour after surgery, was mobilized out of bed. The next day morning when I come to round in the ICU, he's having breakfast bedside, sitting in a chair. The dobutamine was weaned off by post-op day 3. The Impella was weaned to P2 by post-op day 8. We do a turn-down echo, which is when we look at the echo on an Impella of P2, and the ejection fraction had by this time improved to 40%. We did a bedside Impella 5.5 removal on post-op day 9, and the patient was discharged to rehab on post-op day 15. So in my opinion, this, again, as Dr. Savasco said, a paradigm change in our field where we're able to offer these really high-risk interventions to these patients with an assurance that we're going to be able to send these patients home to their loved ones after a very high-risk procedure. Thank you very much.
I'm curious, just to get a show of hands in the audience, how many people use VIS scoring, vasoactive inotropic scoring, in your perioperative or postoperative patients? Interesting. So, this is obviously something that our surgical guidelines now talk about. And I think the watcher patient is that very difficult patient, the patient that may have high-risk features, low EF, advanced age, complex procedure, long bypass run. But they come out of the OR and they look okay. They're on maybe a moderate dose of multiple drips, but you're not on high-dose rocket fuel. And the question is, that patient gets to ICU, what are your triggers for then realizing that patient needs to be escalated, and over what time period do you make that assessment?
Yeah, I mean, it's just, when you start getting calls from, we have mid-level providers taking care of our patients, so the pressors are up. The mixed venous, which was maybe in the high 50s, is now maybe going in the 40s. The urine output, it was 75 the first hour, now it's 40, maybe it's going to go 20. The lactic acid, it didn't really clear. So really within the first few hours, usually you see it within the first 6 hours. Hopefully you don't see it. I'm a big believer in, we're all busy people, we all have other things to do. We want to do the best thing for the patient, do it upfront, one operating room trip. But that's generally what I see. Is these kind of subtle things. Yeah, could you hold on? Well, maybe give him some fluid. Maybe he's under-resuscitated. Maybe you change the vent settings around, get the PCO2 down. There's other things you can do, but I think the writing is on the wall, and it's those things. Pressors up, mixed venous down, lactate never cleared, urine output starting to drop off. That's usually the sign. My phone keeps getting text. Oh, no, I'm up on 10 of levo. I'm on 14 of levo. I'm on 0.06 of vaso. So
text per unit time is a definite.
Yeah.
I'll also add, and Marissa, to your point, we saw that evolution happening in our institution. So, we are a group of about 8 to 10 surgeons, and so although a couple of us are using Impellas very routinely, the rest of them are not. And so we used to see this happen to us maybe 2 or 3 years ago, where we would get these phone calls from the ICU. So-and-so's patient came out. It's been 3 hours. We've resuscitated this patient. We've done a lot for this patient. The inotropes are doubled, tripled now. There is no urine output. Index is less than 2. What do you think you want to do here? And then, of course, we would do a bedside echo and see that the AF is very bad, the index is very poor, the patient is full, the CVP is high, the PA pressures are low, are high, and then we know that this patient needs MCS. Now what we see more and more is the calls come from the operating room. So surgeon's patient has come off cardiopulmonary bypass, does not look good, requiring high pressors, requiring high inotropes, index is low. How about doing an Impella now before the patient leaves the room? So I think that just talks about the evolution of the field and more acceptance from anesthesia and ICU that this is a strategy which is good, which is really helping the patients.
Yeah. To that which has been said, I would also add that I generally agree that it's usually early post-op, but there are obviously cases where a graft will go down, small target, cannot be improved upon surgically or that. And so I think you have to have a low threshold for escalating support, even potentially later in the hospital stay. There are certainly people that have a lot of scar and are going to have more rhythmic burden. And so I think it's very valuable, again, in reducing inotropes. Also, I kind of joke that Impella is the best pulmonary decongestant, better than Robitussin. So sometimes people with bad lungs, it just helps really decongest their lungs, get them off the ventilator. And so I think, having a low threshold to escalate if you need for a variety of reasons, but looking at the index and everything else that's been talked about.
Sir, go ahead, please.
I don't know. Okay. Yes, I remember that, I don't know if David's here, the second case we did in the first live conference in 96 in Oxford, Bob Fraser did off-pump with Impella. So the first question is, how is the experience of pump here with Impella? And second, how is the experience that you have in acute MI surgery with Impella, if you have any? Because I see that it's fantastic for the big change that we need to do in the field. Impella is a fantastic tool, but I'd like to know if you have experience now.
So,
go ahead.
Off-pump Impella,
Yeah.
acute MI off-pump Impella.
So again, first let's talk about the off-pump Impella part.
Okay.
So we've done a bunch of patients off-pump Impella with low EF. Very often these patients have very poor aortas. We can't really go on pump. We can't decompress. And in these patients, I will first put an Impella at the beginning of the case. So start with an Impella 5.5 and accelerate Impella 5.5, then open the chest, take down the mammary, and then do your off-pump surgery. The one thing I will tell you, which a lot of people are concerned about, is possible perforation of the LV free wall with an Impella itself. The one thing you can do is make the Impella a little shallow. So if you make sure that the Impella inflow is in the LVOT and the outflow is in the aorta, it reduces the risk of LV perforation especially when you're doing an OM or a Ramus graft or an RC or a very distal PDA. I think it's absolutely safely doable. And actually speaking, as long as you're able to keep the RV filled, the patient is absolutely stable. It becomes an easy off-pump in a low EF cabbage as compared to a difficult off-pump in a patient who's not managing hemodynamics. As far as acute AMI cardiogenic shock patients requiring immediate revascularization, like the patient we saw earlier, we've done a bunch of them. I don't have any patient which I did it in an off-pump setting. I did them on pump beating hearts. If for whatever reason, if I was worried that I'm not able to manage these patients off pump completely, but I've done them on pump beating heart with a direct Impella insertion. Again, the same thing. It makes the post-operative recovery very, very good.
Okay, thank you.
Quick question regarding last case of the aortic valve replacement with tissue valve. Wouldn't you be worried to injure the tissue valve when introducing the Impella through it?
So I think all of us have done Impellas, direct Impella, especially in tissue valves. What I tend to do is make sure that I don't put the Impella directly, I put it over a wire. So what I'll do in these patients is I'll put a graft on the distal ascending, and I'll pass a wire into the root, and I'll just keep it there. And then when I have cross-clamped, I've done my AVR, under which and I'll place this wire through the valve into the ventricle. And then once the clamp is off, I pass the Impella over the wire into the ventricle through the valve, very, very carefully under echo guidance. We've, as of now, have not had any patient where there's been damage to the tissue valve from the Impella itself, because we get an echo in all of these patients after the Impella comes out. We make sure that the Impella is at P0 when it's going in and P0 when it's coming out, which is what the recommendation is. But we've not had any valve failures because of an Impella at this point of time. Anybody else?
else? Yeah.
Yeah.
I was going to say, I've also done it in a case of a homograft, a very long operation, 10 or 11 hours for endocarditis. I don't think we can tell you there's data to say that it doesn't impact late valve failure. I mean, I don't think there's data like that, but I've also done it where I've put the Impella in directly through the valve before I'm closing the aorta and things like that. So I've put the Impella in beforehand and kept it, so I'm ready to put it in across the valve and then close the aorta. I think we have to do strategies to mitigate it, and I think what he's saying over a wire is the best you can do, but I would say it may have consequences long term, and we don't have data to say that it does not impact the valve.
What is the minimum duration you keep the Impella post-op? Is there a minimum time period or?
I think it just depends on the patient situation. Yeah. I don't routinely get an echo. I think it just depends on what people are comfortable with. I just look at the hemos, watch the end organ function, see how they're doing. I mean, the echo might not look much better initially, but I turn it down to P1. Sometimes I'll just go to P0 at the bedside, and if the hemos don't change and I'm on a single low-dose inotrope and hopefully off pressors with intact end organs, and the hemos don't change when I turn the device to P1 or even to P0, then I'll take it out.
I usually like to set a time frame of 72 to 96 hours, not on some of these super high risk, like, potentially transplant patients, but I do that so that when we come out, that we get to the diuretic phase and we're aggressively diuresing the patient. So I like to have, the measures she talked about, but also to have a kind of set plan that we're going to be aggressively diuresing the patient, because the numbers when you have the Impella in don't even look like the patient should be diuresed, because the Impella is sucking the blood through the heart, but still they should be getting diuresed. So once I see that the patient is comfortably in the diuretic phase and we're getting the volume off, then I feel more comfortable taking it out. But obviously keep it longer if you need to, but I would say 72 to 96 hours is usually what I do.
I'll also add here that there are various ways of managing postoperative Impella usage. Every institution has their own protocol. Our institutional protocol, interestingly enough, is that we actually get rid of the inotropes and pressors first before we take the Impella or start weaning the Impella. Our average usage in our first 150 cases has been about 5 to 7 days. We almost always come out on either P6 or P4. We almost never come out on P8. These patients very rarely require P8 because they're post-cardiotomy, so they just need LV decompression and good index. So very often we'll come out on a single inotrope and Impella at P4 or P6. We first wean the inotrope to off, then wean the Impella, and then take it out. So average is about 5 to 7 days in our setup. And that's what I tell my patients, that you expect the Impella to be in you about 5 to 7 days.
One question, Marissa, I know you were one of the co-authors on the AATS surgical AMI consensus document. One thing that came through thematically in that document was the idea of these acute patients that present unstable, to stabilize them first and then either defer or delay surgery before doing your definitive repair, which is a bit of a paradigm shift rather than emergently rushing people to the OR and then hoping that they weather the storm post-op. But, Kunal, your institution recently just published a paper on mechanical complications of AMI, and how you guys manage it. I know you guys have done a lot of work in that as well, but I'm curious if you could just comment on that as well.
Sure. So we presented a paper recently in AATS about the usage of Impella to actually delay the repair of post-MI VSDs. And so we looked at our institutional data for the last 10 years, and we realized that we had a shift in our management parameters about 3 or 4 years ago, where we now, if a patient of post-MI VSD come in, we don't rush these patients to the operating room. Traditional, thing was, if you can wait longer for a post-MI VSD, the outcome's better, right? And I think Impella gives us this time. So what we've done now is that when a patient comes to us with post-MI VSDs, we put an Impella in these patients so that we can improve these patients. These patients get extubated, get mobilized. Our average wait time from admission to the actual definitive closure was about 2 weeks. So we gave them about 14 days for end organ perfusion recovery. And if you look at it from a VSD hemodynamics perspective, you want to reduce QP by QS as much as possible, right? And so Impella, by reducing your left to right shunting, is going to reduce your QP. and by perfusing the aorta is going to increase your QS. So it's a perfect device for reducing your QP by QS, even better than ECMO, which will increase your QS and marginally reduce your QP, but it does not reduce your shunt fraction. So we've had fantastic results. We've done, I want to say 8 patients, or actually by now 9 patients. We've had 0 mortality, and I can tell you firsthand that these VSD closures are very different from the post-MI VSD closures that we're used to, where the patient are very sick with poor livers and poor kidneys. These patients are routine cardiac surgical patients. They get extubated 4 hours later. We are able to take the impella out in some of them intra-op and some of them post-operatively. These patients behave very differently from the post-MI VSD that we're used to.
And the tissue quality.
Oh, the tissue quality. Oh, yeah. The surgery itself is so easy because by that time, we have fibrotic edges. It's very easy to pass stitches through it. We know exactly how much of the muscle is now dead, how much of the muscle is alive. It's a very different surgery from what I was used to at the beginning of my practice, where it was all hands on board. Oh my God, this patient's not going to make it.
I think the tricuspid tissue comes down and covers the RV side of it when you're applying suction on the LV. So the theoretical concern of pulling blood backward is actually, I think, mitigated from that.
Oh yeah, and absolutely. I mean, we've had no right to left shunting even at P7 sometimes. You just want to make sure that the shunt fraction goes down. You're never going to eliminate the shunt. It's never going to be 0. As long as you're able to reduce it as much as possible, you reduce the shunt and you reduce the pulmonary overflow. That's essentially what you want to do.
How are we doing on time? Do you have any more questions from the floor? Okay. Well, I thank you all for being here today and appreciate your time.
Thank you very much.